All right, we'll talk about hypotension shock, and I'd like to also make it a little bit interactive, so I'd like to ask for your participation along the way. Now, in order to manage a disease entity, we first need to identify it. And in pediatric and older pediatric population, adult, hypotension is the single most important sign that you can actually differentiate shock from babies who are doing okay. So that's not a problem in older children and adults, but in neonates, that's a problem because we don't know how to define hypotension. The only thing that actually we're sure about is that the blood pressure depends on gestational age and also increases with chronological age. These are the two things that consistently been shown. We know little about what constitutes a hypotension, a pressure below which organ function is affected, and also more importantly, organ damage occurs. But clinically, we could define hypotension in various ways, and these are some of the most common ways that hypotension have been described. Mean blood pressure less than gestational age in week in the first few days. Mean blood pressure less than 5th or 10th percentile. Blood pressure less than 28 or 30 millimeter mercury. And more recently, permissive hypotensive has been added to the mix. And that's a definition which completely disregards a numerical value of blood pressure and look at the perfusion. A recent survey from Europe, it's more than 30 countries in Europe, showed that the most common definition that people, the neonatologists, use is the mean blood pressure less than gestational age in week. Now, why most of us think that hypotension matters? There are a couple of reasons. One is that identification shock of the shock in early stages. Now, imagine if you have an insult, let's say hypoxic ischemic encephalopathy, as you just heard Dr. Savage talking about it, or sepsis, then we could actually identify stages of the shock, how it progresses from compensated to uncompensated to irreversible stage. Now, when you have the insult, first the blood pressure is maintained by compensatory mechanisms, and that's when you have compensated shock. When those mechanisms start to fail, you will start developing hypotension, and that by then the shock has entered uncompensated stage. And if it further progresses or our treatment is unsuccessful, then it gets to irreversible damage, organ damage, and death. So it makes sense, in order to prevent shock progressing to the irreversible stage, we should identify it earlier before it gets to this stage. The second important reason that why hypotension matters is the cerebral blood flow and the effect on neurodevelopment. So if we look at the autoregulation, cerebral blood flow autoregulation, this is a schematic drawing where you see the changes in blood pressure and changes in cerebral blood flow, and you see here that you have a plateau where changes in blood pressure does not significantly affect the flow in the brain. Now, it's interesting that in premature babies, this threshold, this plateau, is quite narrow, so which means that we easily can be in and out of autoregulatory plateau, which then result in either low blood flow or too much blood flow to the brain. And to make the matter worse, that this narrow autoregulatory plateau is even completely disappears when the baby is sick For example, if you're sepsis or you have hypercarbia, then you have complete loss of autoregulation. And what that means is that if the blood pressure is low, then you're not perfusing your brain. And if the blood pressure is too high, let's say you start a hypotensive baby with dopamine or any other medication that increases blood pressure, and you don't titrate it adequately, and you reach over here, hypertensive, even normal high blood pressure, then you're overperfusing. So you have the ischemic and hyperperfusion or reperfusion injury. So these are the two major reasons that hypotension and identifying it is become important. Now, before moving forward, let's talk a little bit about the association between hypotension and poor outcome. And there is a lot of controversy of whether hypotension has an effect. It's certainly, from what I explained so far, you can make a case for hypotension causing low cerebral blood flow and causing ischemia and causing long-term neurodevelopmental problem. But also we know that most of us, almost all of us, would somehow treat hypotension. And the treatment in itself, as I just explained, if you have lost your autoregulation and inappropriately titrate your medication of choice, can actually cause harm and lead to poor neurodevelopmental outcome. And then we know that hypotension is a sign, is not a disease in itself in most cases. So there's something else causing hypotension. And that pathology that causes hypotension can in itself have direct effect on the brain. So if you have sepsis, inflammation, chorioamnionitis, in of themselves affect the brain. So here, from the available data in the literature, which are all retrospective, looking at this relationship between hypotension and outcome, we can really not figure out what's causing the poor neurodevelopmental outcome in these babies. Before 2000, almost all studies that have looked at that have blamed hypotension for poor outcome, because until then we all thought that that was the problem. And then after year 2000, magically we thought that treatment is the problem, because that's become fashionable to associate treatment. In reality, nothing has changed. We're still looking at the retrospective data where you cannot ascertain a cause and effect relationship. You can only talk about association. So it looks like we're looking at this picture. For those who you haven't seen this picture, this is a profile of a young woman or an old woman, depending on how you look at it. So this is how we're looking at the data when we talk about effect of hypotension on neurodevelopmental outcome. So if you're biased to believe that hypotension is bad, then you might see a young lady there, a profile, this is the ear, this is the nose. Or if you believe the treatment is the problem, you may see that there's an older lady, and here's the nose and here's the mouth of that older woman. So we're looking at the same thing and trying to figure out what's the problem. And in reality, we cannot do that with the available data. So what can we say? How we should manage babies who are in shock or are hypotensive? We have two approaches that either use evidence-based or look at the pathophysiology. The evidence-based is very important, and nowadays we should strive to use evidence as much as possible to manage our patients. But when we're talking about evidence, what do we have in mind? The best level of evidence is randomized controlled trials. Now, if we're talking about randomized controlled trials, the outlook is very grim, because this is the only study to date that's published that used a randomized controlled trial fashion and used untreated hypotension to look at the outcome. And this was a large, looked at the very large population, over 300 very premature babies. And out of these number of babies, only 10 babies were recruited in 1 year to be studied, randomized to treatment versus no treatment. So the conclusion of this study was that such a study, a randomized controlled trial, is not possible for treatment of hypotension. And the main problem with this study, the reason they couldn't recruit, was consenting in timely fashion. But other reasons were there too. For example, if you look at the babies who were eligible but were not enrolled, most of them received treatment for hypotension. And if you look at babies who were eligible but parents were not approached, more than half of them, the neonatologist said not to approach the parents because they believed that baby needed to be treated. So we have a bias toward treatment. Whether it's right or wrong, that's a different question, but most of us would treat hypotension. That makes it this kind of data to see if hypotension is bad and how to treat it very difficult. But if we look at different level of evidence, then in the literature there are evidence that what kind of hypotension is worse or that we should be more concerned about, then these are the things that you should worry about. One is duration. The longer is the hypotension, the worse the association with poor outcome. If you have loss of autoregulation, maybe because of hypercarbia, maybe because of hypoxia, or metabolic acidosis. If you have hypotension together with any of these problems, then you should be more worried and more be prepared to treat the baby. So the second approach, until we have a nice randomized trial to tell us what baby needs treatment and how should we treat, we need to use a pathophysiology-based approach to identify the problem and direct our treatment based on the circulatory compromise. So with that, we can go to the basics and look at the relationship between cardiac output and systemic vascular resistance, which gives us the blood pressure. So if we break down this relationship to its component, then we see that SVR, the systemic vascular resistance, if there is derangement, you have vasoconstriction or vasodilation, then you could have circulatory failure. Cardiac output is a product of heart rate and stroke volume, and if you break down the stroke volume to its component, preload, contractility, and afterload, disturbances in any of these can lead to circulatory failure and shock. So if we approach every baby thinking in those terms, we're more likely to actually target what the problem is and then more appropriately direct our treatment to the underlying cause. So I put together here categories that we can, when we look at a baby with circulatory compromise, we could put a baby in each of these categories. So one big category is babies with vasodilation. And this is one of the most common causes of hypotension in the NICU. And babies who have septic shock, babies who have NEC, necrotizing enterocolitis, these are the babies who have vasodilation. And the treatment of these babies would be different than the babies who have contractility problem, for example. In this group of babies, we have little data to show actually what happens in these babies. We have data in older children, but in neonate, this is one of the few studies that have looked at babies with sepsis and looked at the babies who actually survived, shown in blue, and babies who died, shown here in red. And what you can appreciate in both groups, the cardiac output was very high. Normal is about 200. These babies had much higher cardiac output, and they had very low vascular resistance, both of the groups. So these are the babies who are vasodilated, low vascular resistance, high cardiac output. And the management of these babies, again, is to improve the vascular tone. Now, what about contractility? There is no data in neonate showing how is the myocardial contractility in septic shock, but in children, we know that 50%, more than 50% of the children with septic shock have either systolic or diastolic myocardial dysfunction. So treatment of vasodilatory shock, volume, vasopressor. So you need to improve the vascular tone. You don't need inotrope. You need to improve the vascular tone. And the second line is steroid. So if you have downregulation of your adrenergic receptor, then you need to actually upregulate it with a steroid so that the pressor would work. Now I'm going to show you a case here. This is a baby who was born at 24 weeks of gestation vaginally. And the baby had low Apgar score and for a brief period also received chest compression. There was no significant metabolic acidosis. Baby's blood pressure was 31/25, so mean was normal of 28. And capillary refill was about 2 seconds, which is normal. So these are the treatment that most commonly we use in the NICU. Either we just monitor the baby or we give a baby a bolus of fluid, dobutamine, dopamine, or epinephrine. These are the most common ones that we use. Now, if we look at this baby, the blood pressure is normal, capillary refill is fine. Many of us would not treat this baby and just monitor. The baby doesn't have metabolic acidosis. But the baby did sustain some degree of hypoxia and asphyxia. So this is a group of babies who are at risk for contractility problem, those with low Apgar scores, those who need intervention in the delivery room, chest compression. And our baby would be put in this category. Now, even though the baby looks good, our assessment of adequacy of circulation is actually very limited. So in this case, even though everything looked okay, if you look at the contractility, and this is a cross-section of the left ventricle compared to normal, I hope you can appreciate that this ventricle is not moving much compared to this one that's contracting much better. So I've put here during diastole, the cross-section of the left ventricle is becoming a little bit smaller, but not much, compared to this one, which is constricting much more. And you can look at the septum, normal versus this baby, and you can see that the septum is moving much better than in this baby. Shortening fraction low, cardiac output very low, normal again about 200. So this baby is clearly in trouble, but we have problem assessing the baby. So assessment of shock is very difficult in the first few days, especially in premature babies. So in this baby, the blood pressure was normal. We know the cardiac output was low. So what we have here is elevated systemic vascular resistance. So when you have two components, you can figure out what is the third and then appropriately direct your treatment. So if I would to ask you what would be the best treatment if you have contractility problem, I'm sure you would use dobutamine as a drug of choice because that's the inotropic agent. So babies with asphyxia or perinatal depression, the primary problem is myocardial dysfunction, and you may or may not have compensation with vasoconstriction. So if you have compensation like this our case here, the recognition becomes more difficult. These babies need inotrope. You don't want to give too much volume for these babies. The third category are babies who have high afterload. And these are babies whom are going through postnatal adaptation, and that can be a challenge for a subset of the babies. If we look at the relation between contractility and afterload, in older children, normal children, we see that this is the relationship. What it means is that as the afterload increases, the contractility decreases. That's expected. Now, in neonate, term babies, you could see that the relationship is much steeper. In other words, with the same amount of increase in afterload, you have more drop in contractility. So let's say if your afterload goes up from 30 to 40, this is wall stress, then your contractility went down by a little bit in older children, but in neonate, this decrease is much greater. And that's the problem that many or subset of babies actually face right after birth. The problem is how to manage this baby is a challenge because the studies looking at this phenomenon have not shown any real benefit from dobutamine or Merinon in this kind of setting. This is a recent randomized trial where they try to address this problem of contractility by giving Merinon, which in some babies can improve contractility. It's actually improved the compliance. And what it showed in this study that when they use right ventricular output or superior vena cava flow, they saw no difference in Merinon versus placebo group, showing that Merinon was not helpful in improving cardiac output. What is the fourth group are babies who have hypovolemia. Now, the things that I've listed here, acute blood loss, a cord accident, these are not very common. So hypovolemia, until very recently, it was thought to not be a major player in causing hypotension and shock. But the recent data from delayed cord clamping and cord milking shows that babies who actually received delayed cord clamping or milking, so they had more volume, tended to have less hypotension, less need for pressors, and also less IVH, which brings up a possibility that hypovolemia may be under-recognized. Now here is a case, and I like to ask you to pay attention to this case because I'm going to ask you a question, how to manage this baby. This is a 5-kilo baby. This is large baby. An infant of diabetic mother who was receiving insulin. This baby had hypotension, capillary refill was 3 seconds, and had moderate metabolic acidosis 2 hours after birth. Baby received 1 normal saline bolus, and he was in room air without any respiratory support. What would you do for this baby? Clearly, the baby has metabolic acidosis, hypotension, and borderline capillary refills. There is something going on. Are we going to do no intervention, just monitor, give a bolus of fluid, another bolus, start dobutamine, epinephrine, or phenylephrine? So I'd like to ask you by show of hand, what would you do for this baby? Again, nobody knows what is the right answer, so don't be afraid to raise your hand. Who would not do any intervention and just monitor closely? Anyone? Okay, no one. Anyone would give another fluid bolus of 10 to 20 per kilo? Okay, we have few, good. And anyone would give dobutamine to help this baby? There are few would give dobutamine. Epinephrine? Epinephrine? Any fan of epinephrine here? No? Phenylephrine? Nobody would. So most of us either gave a bolus or gave dobutamine for this kid. So this is very unique case. This is a group of babies who have diastolic problem. The management of diastolic problem is very different than any other babies that we manage in the NICU. So if you have a baby who has contractility problem or vasodilation and use dopamine, you pretty much addressing most of the problem. But this is a baby who is infant of diabetic mother, so he's very likely to have hypertrophic cardiomyopathy. About 30% of these babies do have some degree, although the number of them who present with, like this baby with metabolic acidosis, is smaller and is unknown and is probably in order of 2, 3, 4%. So these baby, if you look at the normal versus this case, you could see that how thick is the myocardium. I don't know if it projects well, but you could also see in the M mode, you could see this is the normal septum, left ventricle, posterior wall, and you can see how small is the ventricular wall and how thick is the septum. So this is a baby who actually would benefit for more volume because you want to fill the heart. This is a baby who you should not give dobutamine because dobutamine increases contractility. These babies have hyperdynamic heart. The contractility is high. This baby is because of a small cavity and large wall. They have very low afterloads, so the contractility is really good. So either you use a lot of volume or you use a medication like phenylephrine, which is a alpha-adrenergic receptor agonist, which only acts on vascular tone rather than heart. So this is the baby whom, again, you want to use. The problem here is a low preload and dynamic obstruction. So because of hypertrophy, these babies, when they contract, the septum actually blocks the outflow tract of the left ventricle. So you want to use either something to actually slow down the heart rate and possibly contractility, like beta blocker, like esmolol. Again, volume is the mainstay. And then vasopressor, so either vasopressin or phenylephrine would be the third line of treatment. And again, we want to avoid dobutamine, dopamine, epinephrine, because that actually can worsen the obstruction. The last group are the babies who have shunt. And that's babies typically with PDA or other shunt, and we won't spend much time on this. We'll talk a little bit more in the afternoon about these babies. Okay, I'm going to present you another case and see what would be the management. This is a little more challenging. This is a baby who was born preterm at 31-week gestation, one of the twins, twin A. This baby was small, intrauterine growth retardation, and they delivered by cesarean section because the cord blood flow was abnormal in this baby. So the babies were born, the Apgar score was fine, the baby was in room air, no respiratory problem, looking good, but the baby was hypotensive after birth. And he had already received one normal saline bolus, and at 3 hours, even after bolus, the blood pressure remained very low, 34/14, and mean of 21. A 31-weeker, mean of 21, and capillary fill was normal. So what would be the best management for this kid? Now, here are the choices. Again, no intervention, just monitoring, giving a bolus, dopamine, dobutamine, or epinephrine. Again, we don't know what is the right answer, what is the best thing, but let's see what most people do here. This is an area of controversy, obviously. Who would not do anything and just monitors? Anyone? Okay, we have some who would just monitor the baby, would not do any intervention. Bolus, normal saline. Okay, we have one. Dobutamine, dopamine. So most use dopamine, dobutamine. Anyone use dobutamine? 1, okay. Or 2. Epinephrine. Nobody likes epinephrine in Panama. Okay. So so this is a challenge, right? If you were to you need a little more information, probably dopamine would be the safest bet here. Now in this kid, we actually looked at the heart to see what else was going on, and I don't know if you can see it. If it's dark enough, you can see. But this is showing a cross section of the left ventricle, and contractility is normal as evidenced by shortening fraction, which is 34%. So good contractility. Look at the cardiac output. The cardiac output is really high. It's 377. Again, normal average is about 200. So high output. The middle cerebral artery mean velocity is completely normal. So now we have more information that this baby is actually has low blood pressure, but the low blood pressure is because of systemic vascular resistance. So low pressure, high cardiac output, the SVR must be very, very low for whatever reason. Now, when you look at the heart and assess the baby, you may not find the actual etiology of why the baby is hypotensive, but you would find what is the pathophysiology. Would you find what's the hemodynamic here? So we know that the systemic vascular resistance is a problem. So if you're targeting this baby, you want to treat this baby, then dopamine would be the drug of choice, because you would, given these choices, you would actually improve the vascular tone. So anything that would improve the vascular tone. But in this case, obviously, we chose not to do anything because we had additional information. And here's the changes. So 3 hours later, the blood pressure improved to what would be most considered normal and continued to be normal for the next day. And as we expected, the improvement in the blood pressure was because the systemic vascular resistance, as shown here in green, improved. So the blood pressure improved because vascular tone improved on its own without any intervention. So this case shows you that not all hypotensive babies actually need treatment, but only if you can actually verify or have additional information that the perfusion is okay to vital organ, for example, to the brain. So that's the important thing, not to disregard hypotension unless you have additional information beyond your clinical assessment that you can tell what's going on. So we need to move beyond just looking at the blood pressure. We need to do additional assessment. Dr. Morgus talked about functional echocardiography. We'll talk more in the afternoon. There are non-invasive continuous cardiac output monitor that is available and being validated. We found that this technique, which is very simple to use, is basically you put 4 electrodes on the baby and it gives you cardiac output. And we found it to be in term babies, the first couple of days, to be very similar as far as the precision and bias compared to echocardiography. The other way of assessing is to look at the organ flow using near-infrared spectroscopy or other methods. And I would end with this slide, which kind of trying to drive the home message that we need to extend our monitoring capability if we are to recognize shock early on and manage it more based on what is the underlying problem, rather than just using our drug of choice, whatever it is, at the unit we practice, and the way we manage hypotension just randomly. So we need, currently, many people either look at the blood pressure or direct assessment of the flow. We need to move to actually looking at the history, if we actually look at the history and break down blood pressure to its component, cardiac output, preload, afterload, contractility, systemic vascular resistance, and think about what might be affected depending on the history. Is it an asphyxiated baby who most likely would have contractility problem, then would need an inotrope? Is it a septic baby who most likely would be vasodilated and need vasopressors? Then we're actually making a better judgment. But ultimately, if we can do echocardiography ourselves, then instead of guessing what is the problem, we actually can tell what is the problem. Is it vascular resistance? Is it contractility? Now, ultimately, it would be nice to have a way to assess the actual things that we care about, the oxygenation, the perfusion to the organ, primarily the brain. And near-infrared spectroscopy provides some assistance with that regard, but we need more data to know how to use it and what are the cutoff when we should actually intervene, and so we need more data to know how to use NIRS effectively in babies with shock. And with that, I end my talk. Thank you very much for participating in the quizzes.
Bueno, yo tengo una pregunta hacia la doctora Savage. Doctora Savage, nosotros acá, cuando empezamos el programa de hipotermia, nosotros hicimos un abordaje inicial combinado, porque queríamos que todo nos saliera bien. Lo que hicimos fue colocamos a los pacientes que eran candidatos a manta térmica y utilizamos eritropoyetina. Sí, el hematocrito era lo suficientemente bajo y empezamos a tener buenos resultados. ¿Sabe usted de algún estudio que está actualmente realizándose en Estados Unidos o en algún lado sobre el método combinado? So my question is, if when we started the hypothermia treatment here in Panama, we use a combined approach. We did the cooling, whole body cooling therapy, and we also used EPO if the hematocrit was lower enough. And we started with good results. And my question is, do you know of any clinical studies right now using both approach? And what are your thoughts about using this? Because this approach will affect both different aspects of the cascade that we want to prevent in terms of cerebral damage.
So in terms of hypothermia and high-dose erythropoietin, the erythropoietin is not acting through more red blood cells. It is acting directly on the erythropoietin receptors in the brain that will lead to better brain growth and prevent damage. Are they getting that automatically translated? Okay. So the only studies now are looking at hypothermia, which is standard of care, with high-dose erythropoietin. We don't yet know how much, how often, and how long to give the erythropoietin. We are only looking at some of the long-term outcomes right now. So the answer is not out yet, but many, many studies are going on right now around the world. We think within the next year or two, we will have the answer whether it really makes a difference. But just using low-dose regular erythropoietin to prevent anemia does not seem sufficient, although some small studies have shown an improvement. But we believe it has to be high dose for it to be significantly beneficial.
Thank you.
For seizures, which medication are you using? Because there are a lot of studies and of levetiracetam, topiramate, or do we have to use still phenytoin or phenobarbital?
I would say that as a first line, phenobarbital still remains the first choice. But we are using in the US more and more of the Capra or Vasodilation, as well as topiramate is showing up as well. But it seems once we get the seizures under control, the neurologists are adding the Capra more and more. But I still think to start with, phenobarbital has been beneficial. Some fosphenytoin is also being used. And I think it may be a matter of giving the drugs and looking at the EEG to see what is controlling that baby's seizures. And we are seeing some babies, regardless of how much medication you are using, are staying in status and nothing seems to help. Also to add, giving the phenobarbital very high dose, up to 40 milligrams per deciliter.
Doctora, creo que no se ha encontrado la bala mágica para encefalopatía y la mejor es la prevención. I think we have now found the magic bullet in the treatment of encephalopathy. And the prevention is the best way we can give the result. I remember when Maria de Liboria used allopurinol, a lot of medicines, even just a bulb since the 80s. But we try to, if we increase the prevention, we can find very well result. So, in this moment, we have the cooling, but we don't know what we're going to have in the future.
So in terms of all of those treatments, most of the studies, at least in the animal studies, have given the medication before the asphyxia or hypoxemia, which has shown improvement but does not correlate to our clinical world of the baby being born. We don't give mothers these drugs before the baby is asphyxiated. So trial after trial has been disappointing because it has not prevented change in outcome. You are right, prevention needs to be the primary mode, or at least intervention rapidly to prevent the significant secondary damage. But that only decreases it by a certain amount. There is still significant damage even with cooling. So prevention and proper resuscitation worldwide would do the most to prevent HIE in our babies.
Alcanza, si se levanta, creo que me hace la pregunta.
Buenos días. Quería hacer una pregunta. De acuerdo al tratamiento de hipotermia activa, generalmente te recomiendan hacerlo 3 días. Yo en una rotación en Europa vi que eso hay veces lo prolongaban, lo hacían 4 días. Busqué en literatura y no encontré. Quería preguntar al respecto si tenían experiencia prolongar la hipotermia y en qué casos podía prolongarlo. Gracias.
So as I mentioned, there was the recent study from the NICHD that compared 4 groups. One was the hypothermia to 33.5 for 3 days. one group with the 33.5 to 5 days, one group colder, 30 degrees for 3 days, and another group 30 degrees for 5 days. The worst group was the coldest and the longest. The other two groups did not do any better. The best outcome was in the 3 days. We have no information about 4 days. I would recommend against doing that because we don't know, is 4 days going to be more like 5 days or more like 3 days? But we know that it was not beneficial, so we do not recommend longer. There may be another study done in the future looking at 4 days, but right now we can only say we know 3 days is good, 5 days is not good.
I'm only gonna, one more question to Dr. Noori. So, Shahab, we know that sometimes it's hard to, especially in the extreme premature baby, to recognize shock. Sometimes they look like they were in shock, but other times they don't. And other times they just look fine and they're actually, you know. So what would be, besides clinical judgment, what would be other things that you recommend us to do routinely? And what other tools you think that are very important for the neonatologists and the NICU in terms of shock recognition and management?
I think the most important, if you were to learn something, would be functional echocardiography. I think that will open you'll open your eyes, because I can present to you a lot of cases where what I thought was the problem, and then I looked at the kid, the problem was something else. But it takes time, and as we'll talk in the afternoon, this is a skill that you need to develop. It takes time. You need to be in the right setting where you have a mentor to teach you. Near-infrared spectroscopy, I think, is very promising, and there is data. There are a couple of trials that are ongoing using near-infrared spectroscopy as additional tool to define whether that hypotension cutoff can be pushed down and whether it will be helpful. And there are some data in animal that suggests that 50% saturation might be a cutoff that we should worry about when we're looking at the brain saturation, and might be associated with brain injury. But it's at the very earliest stage. I think many of us are using it, and as we're getting more comfortable with it, but the jury's out on how best to use it and how to react to it, because it's more difficult to interpret the saturation in the brain compared to arterial saturation, because that number that we get, it depends on many factors, not just the blood flow to the brain, but also the metabolism of the brain, the percentage of the blood that is in the venous versus arterial versus capillary. So there are a lot of things that goes into it that makes it very challenging, but I think these two are the most promising. I have a question, if I may. It's actually the question, I'm just curious about, the guideline for putting babies on hypothermia treatment is pretty strict and clear. How often, if you bend the rule and you actually put a baby who is more immature or have the criteria that it doesn't exactly match what has been defined, but it's kind of in the gray zone, and if you do, how you would discuss that with the family and
So there are some places, even though the original studies were done looking at 36 weeks and above, some places, including our center, will include 35-week infants because we are often so unsure of the maternal dating for the pregnancy. So we feel we will include the 35-weekers. There is another NICHD study going on right now looking at the more immature babies of 34 weeks and above, so including those slightly more premature. However, we do know in significantly premature babies, certainly 30 weeks and below, being cold increases your risk of death. So for small babies, being cold is a bad thing. In terms of the criteria overall, it's a judgment call. If you felt the baby had 5 or 2 of the 6 criteria, but they were significant, you might include that baby. But it's careful, you must be careful not to bend the rules too much because every therapy does have a downside. And if a baby truly is not going to benefit from hypothermia, it would be wrong to start that. But if you have very close criteria, so if you were 7.16, you might consider it. But you need to be careful not to start using it on everybody.
I have a question for Roberto. Now, you mentioned about the use of ECMO, and that's great that you're bringing to Panama for the neonate. I was wondering about your survival, current survival of babies with diaphragmatic hernia, and from your past experience, you mentioned that most neonate would be put on VV primarily. What was your experience with CDH putting on ECMO? A lot of our kids end up on VA ECMO for CDH. Has your experience been different?
Yeah, in the center where I was, I did my training. It was a reference, a center for referral of CDH babies in the south of the United States. So many, even we received CDH babies from Mexico and from other islands. So Dr. Case had a theory that the best heart support can be given by the double lumen cannula because direct oxygenated blood goes direct to the pulmonary artery. So it creates better vasodilation and they have less problems with pulmonary hypertension. And also the coronary flow gets more richer blood with oxygen. So we rarely put babies on VA actually. Mainly was VV and with good results. His survival rate were 94%, above that. In Panama, we don't have that much of good statistics. It depends in the severity of the CDH. The very easy ones, the ones that doesn't have the liver up or it just has some small intestines, and probably not the stomach or a little bit of the stomach up in the chest, they kind of survive, and I would say 50-50 because we have had them, sometimes they survive, other times they actually need ECMO, and once we reach that point, we have nothing to offer. So definitely to bring that therapy here in Panama, it will improve our survival rate of those kiddos. In the Social Security hospital, where we have the statistics, we get 6 to 8, sometimes 10 cases per year. It fluctuates a lot, but I was looking for several years, and it's mainly like 6 to 8, up to 10 cases per year. of CDH babies. Meconium aspiration is one of the others that will benefit, but with the introduction of nitric oxide, we now save many of those babies. So it will be rare unless they have something else going on or was a very bad resuscitation at birth or something like that. They will have some problems. But yes, definitely the experience of the team, of the center, plays a big role in the survival of these patients.
Bueno, le damos las gracias a los expositores por tan excelente charla.